Hello and good evening to you all. Hope you can hear me well. Hi, Dr. Julia. You can hear me as well?
Yes, we can.
Perfect. Thank you so much for confirming that. And good evening to all of you. Hope you had a positive day so far. And welcome to our online patient meeting. I am your host, Caroline. And before us, there are two events tonight. Sorry. And now we are connected with Dr. Julia from Russia, and she joined our Stronger Together initiative. And of course, she is one of the supporters. But also, let me just simply remind you that we are gathering here every single day from Monday to Friday, so that you can find out a few things, if not more, about IVF treatment. As we know, this is not possible to go ahead with the treatment, but we want to make sure that you will learn and you will be getting ready for your treatment when this will be finally possible. And this is again possible thanks to our ambassadors and partners. You can see them right here on the screen. And of course, without them, this whole Stronger Together initiative that wouldn't be possible. And as I've mentioned, tonight we have another topic to discuss, and this topic is, as you can see right here, unfortunate IVF attempt and what's next. And tonight with us we have Dr. Juliya Voznesenskaya. She is the gynecologist reproductionist at EMC, which is European Medical Center, and she is right now in Moscow. Hi to Moscow as well. Hope you are
Hi.
well. And hi, how are you
Hi. Yes,
feeling today?
fine. We are very glad to be here.
Happy to have you as well. And of course, let me just remind you about some things that how it's going to work. We will start with a short introduction from Dr. Julia, and then she will answer a few questions, that the most common questions. And after that, it will be time for your questions. So remember, you can type them all in the chat section, and Dr. Julia will be answering them for you one by one. Okay. And well, Dr. Julia, are you ready to begin?
Yes, we are ready.
Perfect. Let's go ahead then.
Okay, so we will start. So good evening, Caroline, and good evening, dear listeners. And I'd like to thank you, first of all, for finding the time this evening to be with us. And Caroline also already introduced me. That's why I can go right to my topic, to my presentation. And I think today we have a very beautiful, wonderful opportunity to discuss a very sad thing. It's a failed IVF attempt. And maybe you know, but we know this one, that about half and in some cases most of IVF cycles do not reaches pregnancy. And in this case, patients and doctors want to do something, to pass some tests, maybe to change stimulation protocol, maybe to conduct additional special investigation. But all of us want to have our next IVF attempt is definitely successful. So, for starters, I'd like to clarify what can be considered a failed IVF attempt. Of course, the absence of the pregnancy after embryo transfer is a common situation, but it is also a cancellation of protocol at any stage. For example, when we can start the stimulation and we should stop because we don't see any follicles growing, we can cancel egg retrieval because when we receive patients in operating room and we don't see any follicles there, we can have lack of eggs, so don't receive any eggs after egg retrieval, or our embryologist can receive wrong fertilization or maybe wrong development of embryos. So all these cases can cause the canceling of embryo transfer. And in these cases, we understand that all these patients did not even receive the chance for the pregnancy because we didn't do this embryo transfer in principle. Thus, all these unpleasant stories are subject for our medical investigation, and not only negative ECG after embryo transfer. And we should investigate this story. So as I understand, I have only maybe 5-10 minutes until the questions and comments goes from audience. So I'd like to devote this time to for discussion of two very important points that determine the success of our work. The first one is very special question for the probability of pregnancy in general. I am speaking now not about IVF program, but about the usual way to receive a baby. So now I hope you see the graph. And on the ordinate axis, it is the chance of pregnancy. It is a chance for natural pregnancy. On the x-axis, it's woman age. And you can see it's from youngest to the oldest and from lowest to the highest. So you can see that even we have a young girl, about 22, 24, 26 years old. She has probability to receive pregnancy no higher than 20-25% per cycle. And with an increase of the age, we can see the decreasing of this probability. And especially sharply, it appears after 38 years old. So here already we can make a first very important conclusion that a couple needs time to receive and to reach the pregnancy. So we call it cumulative probability of pregnancy. And because of this one, we give to couple some months, about maybe 6, maybe 12 months, so that they try to get pregnant at home. We don't start our treatment, we don't start to investigate the couple after 1 or maybe 2 failed menstrual cycle. So that is getting a pregnancy at once is problematic for with the conventional pregnancy planning, and it's a pity, but the same rule can be applied to IVF pregnancy. The second very important point, the next one, with a decrease in the probability of getting pregnancy, here you can see this one, the probability of miscarriage is gradually increasing. So for example, if we look for a woman who is 42 years old, the chance for pregnancy is about 5%, but the chance to fail this pregnancy and to miscarry it, it's about 35-40%. So, and this rule, and now we are talking for natural pregnancy. I remind you, so if we go to our program, to IVF program, the situation will be practical the same. And just when we are talking about IVF, we receive the new interesting indicator. It's how many eggs we receive after egg retrieval. And here also you can see a woman. Here is predicted live birth, so how we can see take-home baby. So how many women receive at last the baby and from delivery department. So we see the same trends. As a younger woman is, as a higher pregnancy rate for her. Even if we receive only 4, 5, 6 eggs, it's very low amount. She has good possibility to receive pregnancy. It's about 30. And conversely, if we're talking about elder women, even if you receive about 10, 13, 15 eggs, it's a huge amount for this age, we receive very low predicted live birth. So understanding in this point is very important, and for us and for patients, because they decided to start IVF program, because we need to understand the possibility and how it's work. So, and it doesn't matter, of course, that if we receive a failed IVF attempt and we don't receive eggs, or we don't receive pregnancy, and we didn't do embryo transfer, we just should speak with our patient. So don't worry about this one, we just need to go to another one. So there is a room for creativity, and of course we need to have, if it's possible, some additional tests, and we try to understand and try to find the reason why we don't receive pregnancy. And I think today we can discuss the following points. The first important things, it's how to prepare for IVF program. You see, IVF program is not so difficult. It's, of course, we should have some knowledge, but if I receive the young doctor in 2 months, she will start to do IVF program perfect. But how to prepare? What kind of investigation should we prescribe before IVF treatment? It's very, very important thing. The second one is the management of IVF protocol, and it's also very important thing. How stimulation go on? What kind of medical medicine and how many dosage we choose for these patients, what kind of trigger do we use, and so on and so on. And when we receive the patients from other clinic, or maybe we receive our patients from failed IVF attempt, in all cases we try to go through the previous treatment and understand everything was okay with protocol or something was wrong. Then, of course, in some cases we can order some additional studies and tests. Maybe you will ask us about this one and we will discuss it later. And concerning embryo quality and embryo transfer, it's also very, very important position. We should understand what kind of embryos we receive, what kind of embryo we transfer to this patient, and how was embryo transfer done. Did we receive some difficulties or everything was okay, and so on, so on. So now maybe I can stop with general information, and I hope you have some maybe question or some comments. I will be glad to try to answer this one.
Perfect. Thank you so much for that. And of course, right now we will start with those most common questions, okay, that we receive. But remember that if you have any questions, all you need to do is just simply type it in, and Dr. Julia will be happy to answer, I am sure. Okay, so now let's go to the first question. What can influence the effectiveness of IVF programs?
Oh, so many factors. The first one is, as I talked previously, it's a woman age. It's the strongest factor which can influence for our work. And for every age, we can very strong effectiveness of IVF program. The second one is the quality of lining, or maybe the quality of endometrium. So during the stimulation and before the IVF cycle, we should understand, is it enough, the thickness of the lining, enough for implantation, or is too thick or too thin, or maybe some abnormal, and so on and so on. There are a lot of questions now about effectiveness of fresh cycle and cryopreserved. I know that there are a lot of clinics prefer to do embryo transfer not in fresh cycle, but only cryopreserved embryos, and there is some make sense for this one, but I don't think that it works in all cases. And of course, the most important thing is the embryo quality. But you see, embryo quality is a very questionable question, very difficult question, because of course all of us want to have strong blastocysts and with a good quality, but we know that in some cases we receive a good healthy baby after transfer of embryos which are not so good. That's why to estimate and to predict implantation rate and pregnancy rate for these embryos is very difficult for couple. Generally, for a lot of patients, of course, it's easy, but for every couple is much more difficult. Caroline, are you here?
Yes, thank you so much for answering that question, the very first one. And now let's go to the next one. So, how stimulation protocols may affect the success?
Oh, it's it's a question for whole day. So as you know, we have a huge amount of different protocols for stimulations. It means that we have no ideal protocol. Generally, there are some strong rules for stimulation. As you remember in my previous slide, I show you that pregnancy rate strongly depends on how many oocytes I receive from patients. As more oocytes, as more chance for pregnancy. It doesn't mean that I should receive 100 oocytes per woman per cycle, because it can be not safe for her. But we have approximately amount of oocytes which is suitable for us. It can be different, but generally it can be from 10 until 20 oocytes, which is enough to receive good embryos and to receive 1 or 2 pregnancies. That's why the first important thing to how we choose the initial dose of gonadotropins. If we remember about our ovary, we have some antral follicles. So it's our stock, how many future oocytes we have. So we count this one on the scan and decide how many units of gonadotropins we should offer for the patients. If she's rich for follicles, we can decrease the dose. If she's poor, if she has poor stock of follicles, we can increase the dose. It's very strong rule, and as we know now, it's exactly very important to choose this one, because this dose allowed to grow all these follicles which we needed. The second one is very important to keep these doses during all the stimulation. It's not a good idea to jump with medicine because it can lead to abnormality of growing of follicles and of receiving not good quality oocytes. These two rules is very, very important. And the third one, I think it's also very important how to choose day for egg retrieval and how to choose trigger. Trigger is a special medicine which we prescribe for patients 34 hours before egg retrieval, which allowed us to receive eggs from egg retrieval, after egg retrieval. So we can have different type of trigger, and we can prescribe in some cases double trigger, dual trigger, and a lot of other. And this one also can cause the problem or no problem during the egg retrieval. So I think the great answer on this question is about initial dosage and how many days for stimulation and what kind of trigger we can use before egg retrieval.
Perfect. Thank you so much for providing all the details on that as well. And now let's go to the next question. Is there anything connected with an embryo transfer procedure that may have an impact on IVF outcome?
Oh, it's also very important. You have very important questions here. So embryo transfer procedure is really easy just to perform, but it's very, very important. Generally, what does it mean? I should put embryo in a very strong position in the uterus, and I hope that this embryo will stay there. We should go inside through the cervix, and we should go in the uterus and put it in the middle of uterus. If a woman has no any cervix abnormalities, or maybe a lot of operations previously before IVF cycles, usually it's very, very easy. But we prefer to control our movement with a scan because in some cases you can feel how we go inside in the woman, but in some cases, for example, if there is some problem or maybe the weight is high of patients, the weight of patients is high, that's why the feeling is not so good. So we try to control us with a scan, and our nurse stay and take a probe, and I can see how I go inside in the uterus. Then we should press with syringe, and it should be very, very slowly, because there are a lot of investigation which proved us that if we press quickly, we can destroy the embryos. That's why we do it very, very slowly, and then wait about 10-20 seconds, and estimate the drop of media inside in uterus. And then we will go outside also very slowly. After we remove this catheter, we give it to embryologist, and he or she estimate this one for embryos, because in some cases it's not so often, but it can be in some cases that the embryos can stay there in catheter, and we should repeat this procedure. After embryo transfer, generally bed rest is not recommended. And we also recommend our patients just to go to the toilet and just maybe to have a rest for 10 minutes. It's just because I don't know why, it's just for comfortable, for a comfort of patient. And after this one, she can go out to the clinic. For some patients, we have so-called difficult embryo transfer, when we go inside and we cannot go outside. And for this embryo transfer, we have a special catheter with a hard part which can help us to go inside. And in this case, we can receive some bleeding drop or maybe some painful. Also, of course, we have some medicine to decrease this feeling. But if we don't receive pregnancy after such embryo transfer, we try to understand how to solve this problem, maybe to perform hysteroscopy, maybe to perform something else. But as easy embryo transfer is, as high pregnancy rate we will receive. Caroline? Мы можем не слышать его. So embryology protocols with embryo quality. Maybe I can show. No, I cannot show. Okay, so thanks a lot. So we have here our common work with embryos. So we think that after IVF program, is it successful or not? Every patient should receive 2 papers. The first one is a paper from reproductive endocrinologist about the type of treatment, about the type of stimulation, about medicine, and so on and so on. The second one is much more important for the patient, and the paper about the embryos. So as you can see here, for these patients, we receive 6 oocytes. All the 6 oocytes will mature. We perform ICSI for all oocytes, and we receive 5 oocytes which were fertilized right. And then we will follow the history of all embryos, how they develop day by day. And on day 6, we receive 5 blastocysts, and we biopsy them. So this history is really very important. We understand because all embryos have the special science and special characteristic about the quality, how many cells, and so on and so on. So this is for internal use. For patients, it's in Russian, but I think I can explain everything here. So the patients receive this paper also from the doctor, and the same situation. And after this one, she knows that she has 1 embryos 4AA, second embryos 4AA, and the last one is 2AA. So, and she has in cryobank 3 embryos. And this is the concentration and quality of the sperm which we used for fertilization. It's very important thing to know how our embryos developed day by day. That's why, of course, embryo quality is very, very important, and not only embryo quality on day 4 preservation, but their previous story before this day. And we prefer to give this information for all our patients.
Okay, perfect. Can you hear me, Dr. Julia?
Yeah, we
okay,
hear you.
Good. Just wanted to check. Thank you so much again. And so let's go to this question. Are there any tests that, that every patient after failed IVF cycle should consider?
Oh, of course, it depends on situation, but generally we tried after the estimation of previous cycle, after estimation of protocol and embryos, we will try to understand what to do. First of all, you know, the additional test will depend on how many tests I did before first IVF attempt. So if we control hormone test and we investigate the genetic, so of course we didn't receive this one. But usually, if we don't receive pregnancy, we prescribe karyotype for couple, for men and for women. We want to avoid some rare but very serious condition which can leads to miscarriages or to abnormal pregnancy development. In some cases, we evaluate our lining or endometrium. For example, if we find it that during stimulation we receive some abnormality in the endometrium, for example, too thick, too thin, or maybe another one, we prescribe hysteroscopy. But of course, we don't do it in all cases because you see, usually we receive patients in our clinic with who already did this investigation before our program. But if not, we can prescribe this one. A very difficult question about PGTA. You know, it's a genetic investigation which can allow us to know karyotype of embryos. And of course, it's a good information for us. And generally, the pregnancy rate of these embryos is a little bit higher. But you see, if the woman is elder than 40, 41 years old, usually we don't have enough embryos and we don't have the enough quality of these embryos to perform biopsy. That's why this question is open for our patients, and we discuss the situation with all of them after IVF attempt. And there are a lot of course, some special investigation. It's some error test for lining, or in some cases we prescribe laparoscopy, but it's really depends on previous history for patients.
Fantastic. Thank you so much again for answering that question. And so I believe this will be the last question when it comes to those most common ones. Go ahead with your questions. So again, let me remind you just to type it in the chat section so that we can take them over for you.
Caroline, okay.
Can you hear me? Yeah. There's the next.
Yeah, we hear you not so good, but here.
Okay, that's
Oh,
good.
now it's better.
Okay, not sure. Just please let us know if you can hear me well as well, just so we can
Yeah,
make sure
we
that
hear
all is
you.
good.
We hear you.
Okay. So, are there any additional research being done towards failed IVF cycles analysis?
Yeah, we can have a special tests, but you see, it's not useful for all patients. So, for example, we can remember the test for endometrium receptivity. It came from Spain, error test, and in some cases, when we receive 1, 2, 3 embryo transfer with the embryos of good quality and we don't receive pregnancy, in some cases we can investigate the window of implantation. Some of doctors believe in this idea, some of them know, but this test can be prescribed. We have another option for these patients. For example, we believe that after embryo transfer, we can lose some embryos, even if we see them on the scan and we believe that it's right in the middle in the uterus, but we don't know exactly what is going on later. That's why there are a lot of research which showed us that it can be useful for patients who already had 2, 3 failed, IVF failed, to prescribe oxytocin inhibitor. It's a medicine which we can use intravenous as intravenous therapy during the embryo transfer, and this medicine block all oxytocin receptors in the uterus for 5 days. We did it here in our clinic. I cannot say that we have a great effect of this treatment, but in some cases the patients feel much more comfortable after embryo transfer and they don't feel any pain or maybe any discomfort, which can be after embryo transfer, especially in the fresh cycle. What else? There are a lot of off-label therapy, that had no proof that it's work, but some patients prefer to do this one. It's HLA investigation. It's the investigation for hemostasis, polymorphism, and so on, so on. But I don't want to talk about right now because generally in the big investigations, they didn't show any influence for pregnancy rate.
All right.
All right.
Perfect. So much again for answering those questions. And as I mentioned, we will now start with your questions. We do have some questions ready, so let's begin with this one. So do you think the supervision after the embryo transfer, including tests, medication, and dosing corrections, depending on the test results, may have an impact on ongoing pregnancy?
Dosing correction depending on test result? Do you mean dosing correction during stimulation, depending on test result?
After embryo transfer.
After embryo transfer. It's another very interesting play. Yeah, it was popular a few years ago. You see, maybe 5-6 years ago, we controlled our patients because we prescribed some progesterone to feed the pregnancy. And we prescribed some blood tests for progesterone level, for estradiol level, or maybe for another one. But generally, we didn't receive any correlation between these patients. That's why we control this one only in one cases if we have the high risk of OHSS syndrome. If we receive a lot of eggs, but we prefer to do embryo transfer. In this case, we try to control blood test to understand do we have any dangerous for this patient or not. Concerning other cases, we don't do any control. Only we prescribe the blood test for ECG in 10-11 days after embryo transfer.
Okay, perfect. Thank you so much for your question and your advice on that, your explanation to it. And let's go to this one. You already have talked about this, actually, ERA test, but what do you think about using ERA test and similar products? What are the indications for using them for patients?
You see, it's a good test, and it's exactly that position that if you don't understand why I don't receive pregnancy, for example, I have younger women and a lot of embryos, and even these embryos went through the PGT-A test, so I know that I transferred 1, 2, 3, 4 times excellent embryos, but I don't receive pregnancy. That's why we try to find the problem in the lining. Maybe embryo doesn't find the connection with the lining. Maybe we have no when we do embryo transfer, the embryos cannot find the right place in the endometrium. So in this investigation, ERA test or some other the same, they try to understand: do we have the do we choose the right time, the right day for embryo transfer? There are some investigation which show us that pregnancy rate is higher in this after this test, but there are a lot of trials which showed us that there is the same. That's why in some cases we advise this one, but even women had previous pregnancy, for example, she had already children, or maybe she had a pregnancy in her natural life before IVF treatment. We understand that window of implantation is normal. So for this woman, we don't prescribe this test. But if this is infertility without pregnancy, without previous pregnancy, and we can think about very rare condition, so okay, we can prescribe this one and try to do the embryo transfer according to this investigation. Generally, I cannot say that we show a great effect also of these tests.
Okay, thank you so much. And so there's the question, how can we increase the number of follicles?
Oh, it's our daily work. Yeah, it's very difficult question. Increase, it's really very difficult. So maybe can you show my presentation, because I had
Yes.
one slide there about the number of follicles. We colored
Yes.
this one in black color because it's also that story. So here we can see how many follicles we have during our life. And when we are a young girl and we just born, we have about 300,000 follicles. Yes, and approximately. And then, for example, when we are 20 years old and nobody of us think about the pregnancy, but we lose almost half of these oocytes. That's why in the age of 30, 40 years old, we have, yeah, it's about 65,000, and then you see the number decreasing is very, very sharply. So it's a natural process, and we cannot influence for this one. That's why for us it's very, very important to receive patients for IVF before, as early as possible, because here in Russia we have a great problem. Then we receive patients too late, and we don't do anything, and we cannot help her. Approximately age in IVF clinic is about 40. That's why it's usual we call these patients poor responder, because we stimulate there and we receive only 2, 3, 4, 5 eggs, and that's all. And the situation repeat after all cycles. That's why there are a lot of methods to help and to try to increase the number and to increase the quality of these eggs. We know some special types of stimulation, dual stimulation, duostim, the stimulation in the second phase, some special protocols which which can help us to receive not more eggs, but maybe the better quality. And we can prescribe some special therapy before IVF cycle. So it's about androgenics priming. It can be hormone replacement therapy. There are a lot of methods which are not used routinely. For example, IVRA and the using of stem cells, but it's not allowed to offer for general population. But generally, it's bad game, because all this work when the woman is young. For example, you remember also the slide, when the woman is young, even if I receive 1 or 2 more eggs, I increase the pregnancy rate really. But if I receive for woman who is 40, 1, 2, 3 additional eggs, generally I receive the same pregnancy rate as before, as without this treatment. That's why I think it's not so good answer, but we don't have any strong, and we don't have any good preparation for this woman and for these ovaries.
Perfect. Thank you so much for answering that question and showing us the details as well. And now let's go back to the question that we have right here. So, do you think it's important to keep track of fertility level during stimulation, just in case follicles aren't?
I think it's more important thing to keep track for progesterone level, because estradiol level, we can predict this one. We know that approximately for one follicle we have about 300 picogram of estradiol. That's why it's not so interesting. But progesterone elevation before egg retrieval is much more interesting point. And if you receive this problem, we should stop with fresh embryo transfer. Early, we controlled estradiol level during the stimulation and after egg retrieval in case of OHSS syndrome. But now we understand that we have no correlation between estradiol level and the severity of OHSS. That's why routinely we don't do it, but we routinely control progesterone level during the stimulation.
Right, perfect. Thank you again for your question and helping out with it as well. And there's another question. So, does abortion affect follicles level and quality?
Follicles levels and quality. What do you mean abortion? The abortion affect follicles? You mean the previous pregnancy with abortion?
Yes, if you could perhaps get back to us what you mean exactly, okay? So I guess we just need to wait, okay, for the patient to actually write it down what she means exactly.
Generally, I don't think that miscarriage and abortion can affect the follicle levels. For us, it's more important if woman had previously pregnancy. Of course, it will be better to have deliveries, but even if she had pregnancies which finished with miscarriage or medical abortion, for us, it's not good information, but we understand that she can receive pregnancy. That's why the great influence for follicles level is age, is a life, smoking, alcohol, working in some places, operations, of course, the family history, because always we ask our patient about the menopause from her mother, sisters, and grandmother. So this one is much more important than pregnancy previously in advance.
Okay, thank you. Thank you so much for that, answering that question as well. And let's go back to your presentation, actually, because there's a question. Are these embryos reports you showed us generated through time-lapse monitoring on your presentation?
Okay. No. So these embryos were not showed with help of time-lapse monitor. We had this one in our clinic, and it was also very interesting to follow for embryos' life. But generally, we try to evaluate them every day. And after fertilization rate, our embryologist estimates them for the growing, and they count how many cells and what kind of quality of this health of the cells they have. That's why this history should be done for all embryos, not only in case if clinic use time-lapse monitoring.
Perfect. Thank you once again for clarifying this for us. And there's another question here. So during the transfer or after transfer, can I expect bleeding, and how long the bleeding can take? Then is it normal to have bleeding? Do we have to worry about it?
Normally, you shouldn't have this one. And normal embryo transfer, we don't see any bleeding. Usually when I have a consultation after embryo transfer, I talk my patients that today you can have some discomfort in the abdomen just because of speculum and because I went inside her. And in the day of embryo transfer, she can have some spotting, that very, very light spotting of brown color. It's just because of their catheter. But if in the case when we have really very difficult embryo transfer and we should use fast catheter, so it's not soft, but very strong, yeah. strong catheter. Of course, in this case, we can disturb the cervix and we can disturb the lining. And in this case, our embryologist show us bleeding, blood drops inside in catheters, and the patients also can see this one after embryo transfer. But normally, no.
Okay, thank you for explaining this to us as well. And now is the next question. So, is it possible to have a follicle stimulation with AMH level of 0.02?
Yeah, it's possible. Of course, it's not so good level for MH, but maybe I will repeat the same, but it will depend on the age. For example, if you are 45 years old and the MH is only 0.02, of course, the chance for the pregnancy is very low. But if you are 30, 35 years old, we can try. And we are here very clever and we know everything, but our patients can be surprised for us. And in some cases, for example, we predict that we don't receive answer for stimulation and we don't receive eggs and we don't receive embryos, and we offer for these patients egg donation. But if you don't try, you don't know. That's why even if we understand that the pregnancy rate is very low, but our patients didn't have previous cycles, so she just came for the first time to reproductive endocrinologist and she asked about this one. We have an agreement with her. Okay, I will try to wake up your ovary and I can offer you maybe 2-3 types of stimulation, and we try. And if we receive the follicles growing and we receive eggs, so we are already winner and we can wait for the pregnancy. But if we don't receive this growing, or for example, we receive these follicles, but we don't receive eggs after egg retrieval, or we don't receive embryos because of the wrong fertilization, we should stop. Because here we often very sad story also when our patients try to continue the stimulation month by month, and they can do it 1 year, 2 years, 3 years, and without any stopping. That's why we try to have a position that, okay, I will work with you during 3 cycles, and then we choose what to do. To go, if we have our embryos, we do embryo transfer. If not, we will discuss egg donation program.
Thank you so much again for your advice and your explanation to this question as well. And there's another question. So, sorry, what was the medication that you give intravenously to patients
Oh,
during embryo transfer to block oxytocin receptors for 5 days? You said it relaxes them?
yeah, it's oxytocin inhibitor, and it's called atosiban. Atosiban. It's ampoules which we mix with solution, and there is a strong protocol how to use this one. So the patients come for embryo transfer 2 hours previous in advance, and we put the first ampoule in intravenous. Then she receives the same therapy in very, very slow way, yes, and because there are only 25 milliliters, but you should prescribe it very, very slowly. That's why approximately 1-2 hours before embryo transfer, she receives this therapy, during embryo transfer, and about 1-2 hours after embryo transfer. So now, as I know, the company works for this medicine, which we can use in tablets, but right now we don't have this one, but we hope that we will receive it soon. That's why, according to the investigation, we can prescribe this therapy for patients who already had 2 or 3 embryo transfer with the embryos of excellent quality. So it works only in case if you don't have any trouble with embryos, and we do embryo transfer and we don't receive implantation. We checked everything, the uterus, the karyotype, and so on and so on, but we don't receive pregnancy. So normally, as I know, that there are a lot of clinics offer this therapy in these cases.
Excellent. Thank you so much again for answering that question. We have another question here. Is there any way to increase egg quality as I do not get blastocysts? Should I transfer or freeze on day 3? I'm 40 in May and only get low numbers.
Oh, very good question, really. Yes. You see, there are two positions normally now in our reproductive world. The first one is to stimulate a patient to receive as more eggs as possible, then cultivate them until blastocyst, then do PGT, and then try to do embryo transfer. It's a very good way, but normally only 7-10% of our patients elder than 40 years old reach this embryo transfer. That's why we prefer to use another way to do embryo transfer. What do I mean? We stimulate patients and we receive maybe 2-3 eggs. We fertilize them. And if we don't have any contraindication for fresh embryo transfer, we can do embryo transfer on day 2nd or on day 3rd. We understand that if we do embryo transfer, we will have the chance for the pregnancy, even if I don't like the quality of the embryos, even if they are not blastocysts, even it is a fresh cycle. But if embryos are inside in uterus, the chance we receive the chance. That's why I know that some of our colleagues in USA and in Europe also use this way to receive eggs, fertilize them, and to transfer as soon as possible. Because for this patient, we also have very common situation. For example, when the woman received already 1, 2, 3, 4, 5 cycles of stimulation, but no embryo transfer at all. So the question is, for what this one? Just to stimulate and just to think and to see that your embryos stopped to develop in our lab. So we try to perform embryo transfer and wait for the result. Of course, if we do this 1, 2, 3, 4 times and we don't receive pregnancy again, we will start again to speak about egg donation, of course, because for me it's very important to give you pregnancy. For patients, it's much more important to receive their own baby. But we should find the middle in our fight against the infertility. That's why for us, really, it's enough to do 2-3 embryo transfer and to understand what is the reason of not receiving pregnancy.
Okay, thank you so much again for answering the question and for your on point question as well, for sure. All right, so there are like 3 questions left, I believe, but of course, so we will be slowly finishing. However, just let me remind you, if you have any questions at all and you would like to ask Dr. Juliya, go ahead and do it now. This is like your final call for the questions, okay? And now let's me go to the next question here. So can I get pregnant with the help of IVF using donor eggs if I'm going through perimenopause?
Oh, you do, and it will be very easy. You know, we can wake up our uterus for periods, and we had a lot of patients who are already have menopause, and they are older than 50, 55 years old, and even 60 and 65 years old. So we can have a different situation in our lives. That's why in this age, in some cases, women want to receive babies. So we prescribe hormone replacement therapy. Usually it's enough about 3-4 months for this one to wake up lining, to wake up uterus and to grow uterus. And then we will start for the cycle. We fertilize oocytes from donor with the sperm of husband or just with the sperm, and do embryo transfer. And you know, the pregnancy rate in this case will depend on donor age, not on uterus age. It's very interesting differences, and this point allowed us to receive pregnancy even in a very old age. I don't think it's good to receive babies when you're older than 50 years old, but I just repeat, we can receive some difficult situation when, for example, the children died, or maybe another one, and it's a single opportunity for women to receive the new family. That's why, of course, it's a good way, and the pregnancy rate is approximately about 50-55% per embryo transfer.
Okay, fantastic. Thank you so much again. And actually, there's a follow-up question straight away, so just give me a second right here. So may I ask, what is the age limit in your clinic to receive egg donation treatment?
Russia is a special country, so we have no age limit here. I don't know, is it good or not? My eldest patient was 64 years old. I'm not proud of this one, but it was really very sad story. That's why we did this program, and already now she has 3 years boy, son, and everything is okay with her, and everything is okay with him. Of course, we try not to offer this treatment for the patient who is older than 50, but of course we can do it. Right now, yes.
Okay, thank you for clarifying this one for us as well. And there's another question here. So I am 33 and my AMH level is 7.9. Is it too low for my age? And if so, what can I do to increase it?
So I don't think it's too low. It depends on in what unit it was measured. But I think the most important thing is that you are only 33 years old, and even if you have only one or two oocytes, the chance for the pregnancy is a good. That's why when we have the situation when the woman is young, but the ovary is not so good, in this case, the preparation for IVF cycle is very, very important. And in our clinic, we prescribe some special therapy 1 to 3 months before the stimulation. I mean the testosterone therapy or some else, and we receive good answer on this therapy. And in this case, we also can prescribe so-called duostim. Duostim as a position when we prescribe in one menstrual cycle 2 stimulations, so you have 2 egg retrieval in one cycle, and we try to bank oocytes or embryos. It depends on do you have the partners or no. And if we when we receive approximately 6, 7, or 8 eggs, we can fertilize them together and then perform embryo transfer. So just you can have a longer period to reach the pregnancy because of oocytes amount, but 33 years old, it's very, very good age to receive pregnancy.
Fantastic. Thanks again for answering that question. And now let me go to the next one. So how soon after a failed IVF attempt can a patient try again? Is it possible to do back-to-back simulations, or do you have to wait a month?
You see, it also depends. 10 years ago, when I did the protocols, it was a strong rule to have 3 months 3 months pause between the stimulation. Now we have now this rule, and after failed attempt, if we have embryos which were preserved, we can do embryo transfer in even in next cycle or maybe in 1 month. It will depend of ovaries condition. And it will depend on do I have to offer you to investigate something. So for embryo for the transfer after pre-cycles, we have no any time restriction. If you're talking about the new stimulation, generally we try to have 2 months between this one, but normally we don't lose this one. Maybe we can, if we have poor ovarian reserve, we try to receive this eggs in natural cycle between these two cycles of treatment, because every egg can be a chance for the pregnancy. And in 2 months, we can repeat this cycle of stimulation. If you're talking about duostim, now we have triostim. When we prescribe stimulation right 3 days after egg retrieval, we can start again. After 3 days egg retrieval, we can start again. It's not easy for patients, of course, because I think they should live in our clinic. That's why we don't offer more than 2 cycles. But in some cases it's work. But if you have time, if you're not 43 years old, and if you have the normal amount of your eggs, 5, 6, 7, 8, or maybe more, I think you should have rest minimum 2 months between this therapy.
Fantastic. Yeah, again, thank you so much for your advice. And there are 2 questions left. Once again, if you would like to ask anything else, just go ahead and type it in right now. And let's go to this one. So, is PRP a good idea to increase the quality of the oocytes? Do you also have such option at your clinic?
It's a good idea, but I don't know is it work the same as it's a good idea. It's also experimental methods, and only some clinic can offer for this one for patient. And generally in Russia, we can use this one inside in uterus and inside an ovary. This idea is good. Why? Because we use the material from the patient, so it's not the medicine which we don't know how to work. It works better when the patient is young. If a patient is older than 40 years old, so it works much more worse. That's why routinely we don't use this one, and maybe we had only a few patients for this one. Truly, we didn't see any improvement of function of ovary, and we prefer to use methods which went through the randomized controlled trial, because we can offer a lot of methods to patients, but I'm not sure about the safety of this one. For me, it's most important not to harm you, and only the second point to give you pregnancy. But all these methods, it's just under investigation. So I think we receive their first result, not first, but the result which can allow us to prescribe it to patients only maybe in a few years. So when we will see this one, we will decide to use this one or not.
Thank you so much for answering that question. And look at this one. So, is there a statistic for all IVF babies and what is their actual health?
Yes, we have a lot of articles and a lot of investigation about our babies. 2 very important points which are very seriously investigated during last 40 years. The first one is the health of our women who went through the IVF cycles, about cancer and so on, and the health of our babies. And generally, we don't receive any additional abnormality for our babies if we compare them with natural babies. But we know that the health and the age of women who come to IVF clinic is about 40 years old. I don't remember when I receive patients who is 20, 25, or even 30 years old. So we understand that we are not so healthy when we are 40 years old. And that's why we should compare our babies and our pregnancies and deliveries with the same patients, but after natural fertilization. That's why if we just compare, we don't receive any problem with the babies. if we, in some cases, we can receive some obstetrician abnormalities. For example, we receive more cesarean section, we receive more premature deliveries, and we receive different weight of our babies. In some cases is more, in some cases is lower. But as all investigator wrote, it can be not because of IVF, it can be just because of the age. Because the same condition we receive from patients who received only stimulation, not without IVF, just the stimulation for follicle growing, and that's all. So generally, we don't receive worse babies after IVF treatment.
Thank you so much again for providing us the details for this question. There are two more common questions, and here's the first one. Those for duostim, how long after the first egg retrieval do you start injections for the second stimulation? You said 3 days, and is the protocol and dosage usually the same as first stimulation?
Yeah, generally we have few types of duostim. The first was one we call Chinese protocol. The second one is Spain protocol. They differ from each other, but generally we start 3-4 days after egg retrieval. And in Spain version, we should prescribe the same therapy as in previous cycle. In Chinese version, it's much more interesting, I think, this protocol, because we combine 3 types of medicine during stimulation, the tablets and injection. And in the second cycle, they prefer to prescribe more units of gonadotropins than in previous cycles. But you see, it depends, of course, of how many follicles we see after egg retrieval, 3 days after egg retrieval. Normally, we offer this one only for poor responder, when we receive only 2, 3, 4, maximum 5 eggs. So we used all these types in our clinic, Chinese and Spanish protocol, and we don't receive any differences concerning the eggs amount and quality, but Chinese version is much more cheaper. That's why normally we try to use this one, because IVF it's of course expensive procedure. That's why if we can do it cheaper for patients, we try to do it.
Okay, perfect. Thank you again for answering this. Yet another question. And it looks like now it is our last question for tonight. So let's get to it. I'm brown, my husband is white. Is it possible for you to find a donor that match my characteristics? Or is it possible to use my daughter as my donor?
Oh, in our clinic, we have some oocytes from woman who is brown, so we can offer you. And concerning your daughter, in Russia, we have a very strong legislation concerning who can be donor. It should be woman from 20 until 35 years old, and she should be very, very healthy. So normally, when we decide to use relatives as donors, we invite them for estimation. Maybe we receive some information from the native countries about general health, about menstrual cycle, and so on, so on, so on. And if we don't receive any problem with general health and with the donor at all, yeah, she can do it. If you and your husband agree with this one, and she agree also. But it's not so rare situation. You can find 19, so you should wait 1 year for her. But really in Moscow we have a lot, not a lot, but some banks which can offer you to use brown eggs, and we are the same.
Okay, and there's a follow-up question, so let me show you.
I don't remember the country. Angola. I don't. We can clarify what kind of country, but she's very, very beautiful girl. I remember her.
Okay, thank you so much. So it's possible, just to clarify, it's possible for you to reveal the nationality of the donor as well.
Of course, it's very important because all patients, when they choose the eggs, they want to know more information about these girls, and the nationality is one of the questions.
Okay, thank you so much again for answering those questions. Someone is typing, so I just want to make sure that we have answered all the questions. At least at this point, we do not have any more question. So
Oh,
just a follow up right here. So not too dark skin. So I guess you are just. It is still possible, right?
yeah.
And sorry, there's another question at this point. So can I see pictures of the egg donors?
You see, we have a law here in Russia about the information which we can open for patients concerning donors. And normally it's description about the nationality, weight, height, and hair colors, and so on. And we can ask a woman about the photo. If she allowed us, we can use this one. If not, it's impossible to use. So when we ask our sperm donors, they they all gave us these photos. When we asked egg donors, some of them gave us these photos, some of them prohibited. That's why it depends on what kind of girl my patients choose. And of course, we try to show, but here is a very psychological, maybe a point. I don't know, is it so important to see? Because concerning my experience, I think it's much more interesting to forget how you receive this pregnancy. That's why the majority of our patients prefer not to know a lot of not to receive a lot of information about donors, just skin color and some important things, maybe blood type and so on and so on. And I remember only a few cases when our patients wanted to know as more information as possible. I don't know is it good or not, because when we receive this baby, I think I will not remember about how I received this one. It's my baby and my baby from my husband, so I don't want to discuss, maybe to remember what kind of option was done when I received this pregnancy. But of course, it depends on patients. So if they ask us, we try to find this photo.
Okay, thank you so much for clarifying. Definitely important question. And actually, there's a follow-up here. So, do you have a mix of ethnicities at your clinic when it comes to donors? So, beside Caucasian.
Of course, we have, but you see, in Russia, it's popular as just white skin and that's all. But we try to have in our bank eggs from different nationalities, which can come to us from different country, because we worked before COVID, worked with China. That's why it was also popular to use these eggs. And we worked with some countries from Europe, and it was popular to use very white colors of donors. That's why we try, of course. If we receive some patients and we don't have these eggs in our bank, we can try to find these oocytes with our colleagues in another clinic or maybe in another bank. And generally, I don't remember the situation when we didn't find them.
Okay, perfect. Thank you so much. Again, short question, very short one. Have you ever had any, sorry, Caribbean? Anyone from Caribbean, perhaps?
So maybe I should clarify, because there are a huge amount donors in our bank. That's why I just should check it one. I didn't know that you interested in our bank, but we can clarify and we can send the information about what kind of donors do we have right now.
Okay. Perfect. And of course, remember that you can simply use the link that I have just sent you in the chat section, and that way you can ask any other questions you will have for Dr. Julia and her team. They will get back to you, I'm sure. So, of course, with this same link, you will actually be able to rewatch this as well in a few days' time. So make sure to keep it if you wish to do it. And I believe that was our last question for tonight. So thank you so much for joining us tonight for all of your questions. I really believe that you have just got few details that are important and useful for you. And Dr. Julia, what can I say? Thank you so much for joining our initiative. Thank you for your time and, of course, your expertise. I can only just show you that there are patients definitely that find it very useful. Thanks so much. Very useful and helpful. More thank yous coming.
Thank you also, because it was the first experience for us. So as I told previously, generally we get used to prepare presentation for the doctors and not for the patients. So for us, it's a really great experience because it's very important to receive the information from patients, what is important for you, because from our side, it can be another thing. So thank you, really thank you for this offer and for your time and for your question. Because I understand that you know about IVF a lot, because the question was very, very strong and very important for us.
Fantastic. Thank you so much again. And well, I just wanted to simply add that we will be back here at 8 p.m. UK time tonight. So stay tuned. We have another topic to talk about: egg donation, why IVF with donor eggs may fail sometimes as well. And with us will be Dr. Valentina Denisova, and she will be ready to answer your questions as well. And once again, Dr. Julia, it has been a pleasure. And well, you have been wonderful. And as you can see, there are more of those thank yous coming. And well, thank you
Thank
so
you.
much. Have a
Thank
lovely
you.
evening.
Thank
It
you.
was
Good
good to
evening
have
for
you
you
here.
also.
Perfect. Thank you so much. And
Thank
everyone, have a lovely evening. But I also hope that you will stay with us and you will join our next event at 8 p.m. UK time. So very, very soon. Okay, perfect.
you.
Thanks. Bye.
Thanks. Bye. Bye.